All right, so a very good evening, everyone. So I welcome you all to this particular session on the discussion of the emergency medicine MCQs. So until now, we have tried to discuss the various system-wise emergencies like neurology emergencies, cardiology emergencies, endocrinology, then gastroenterology, nephrology, connective tissue disorders, then drug overdose and poisoning. So the individual system-wise emergencies like we have discussed in the previous sessions. So now in this particular session, I will take up the discussion on the multiple choice questions related to the emergency medicine topics itself. So I'll discuss this particular MCQ session in 2 or 3 parts. This will be the part 1. So most of them are completely the clinical scenarios, and most of them are like what will be the diagnosis or like what will be the first line treatment with that particular emergency coming up to you. Okay, so this particular session will be definitely be useful for the students who are appearing for the NEET PG exam that is on March 5th, 2023. Right. So having said this, now let us start with the important MCQs related to emergency medicine. So this will be the first question. Just give me a minute. Right, so this will be the first question. That is, a 62-year-old man is and ventilated in the ICU after severe subarachnoid hemorrhage. Okay. He has an intracranial pressure in situ which has been reading 15 millimeters of mercury consistently. That is the intracranial pressure. He is being sedated and analgesized with propofol and as well as the alfentanil infusions. On a sedation break, his intracranial pressure increases to 45 millimeters of mercury and the pupil increases in size bilaterally. His mean arterial pressure is 90 millimeters of mercury. Which would be your first action to manage his intracranial pressure? Administer mannitol bolus, administer neuromuscular blockade, increase propofol and alfentanil infusion rates, refer to neurosurgery for decompressive craniotomy. Fifth option, remove the intracranial pressure monitor. Yes. So what do you think is the correct answer in this question? So first of all, you need to be very much aware of how much will be or how much is the normal intracranial pressure in an adult. So the normal intracranial pressure in an adult will be less than or equal to 15 millimeters of mercury. So now this patient, when he is on the analgesia like propofol and as well as the alfentanil infusion, that is sedation and analgesia, the intracranial pressure which is being maintained is less than or equal to 15 millimeters of mercury. But whenever there is a sedation break, the intracranial pressure is increasing to 45 millimeters of mercury. When do you call pathological intracranial hypertension? We use the word pathological intracranial hypertension when the intracranial pressure increases to more than or equal to 20 millimeters of mercury. Right. So whenever there is like sedation break, it is increasing to 45 millimeters of mercury. Okay. So what do you think is the correct answer in this question? No, it is not A. It is not the first option. Now let me tell you. Now, what are all the first line or the initial strategies to manage the raised intracranial pressure? So now what is that we are concerned about the problem in this patient? That is the intracranial pressure is increasing whenever there is a sedation break. So what are the initial strategies to manage the raised intracranial pressure? First and foremost, very important is you need to give adequate sedation. That is a very important part of the treatment for raised intracranial pressure. And the next important point is like the individual should be made to lie in the sitting posture, right? Sitting the patient up to ensure adequate venous drainage from the head of the individual. And the third important is like you need to maintain the ventilator to low normal end tidal carbon dioxide, right? Low normal end tidal carbon dioxide. So these are the three important initial strategies, right? Now when these particular initial strategies fail, then the other part of the treatment will be neuromuscular blockade and administering mannitol or hypertonic saline. Now in our options, like we have the propofol and as well as alfentanil infusion, which comes under your sedation. So what will be the correct answer in this patient is increase the propofol and alfentanil infusion rate. Now only after doing these three things. If the intracranial pressure is not reducing, then you need to administer neuromuscular blockade, administer mannitol or hypertonic saline. Okay, and when is your neurosurgical consultation which is being required? Right, so a neurosurgical opinion may be appropriate if the above strategies are unsuccessful. That means you have given sedation, you made to lie down the individual in sitting posture for adequate venous drainage, and you have maintained ventilator with low normal EtCO2, adequate neuromuscular blockade, you have administered mannitol or hypertonic saline. Even then, if the intracranial pressure is not reducing, then you can take the neurosurgical consultation later. Okay, so the correct answer in this particular patient is the option C, right? Now, so that was the first question related to how to manage the intracranial pressures in the emergencies. Now, you take the second important clinical scenario, and if you have any doubt in the first scenario, you can just let me know. I'll definitely clear your doubt. So the second scenario is a 45-year-old man is admitted to ICU. Yeah, low normal. Okay, yes, Meghavi, I'll just answer your question. Right. So what do you understand by this word low normal EtCO2? Right. First of all, what exactly is your EtCO2? EtCO2 is nothing but end tidal carbon dioxide. So end tidal carbon dioxide is the level of carbon dioxide that is released. I'm telling you the meaning of this EtCO2. It is the level of carbon dioxide that is released at the end of exhaled breath. It is the volume of carbon dioxide that is released at the end of exhaled breath. That is what is called end tidal carbon dioxide. Okay. Now, what exactly this EtCO2 reflects? The EtCO2 levels reflects the adequacy with which the carbon dioxide is carried in the blood back to the lungs and exhaled out. That is what your EtCO2 means, right? And how much should be that low EtCO2 levels? That should be nearly around 36 millimeters of mercury. Okay, so that is what is your low normal EtCO2 means. Okay, right. So having said this, we'll move on to the next clinical scenario. So the next clinical scenario is a 45-year-old man is admitted to the ICU after banding of esophageal varices and significant upper gastrointestinal hemorrhage. He has alcoholic liver disease and continues to drink 1 liter of vodka per day. He is hemodynamically stable with good gas exchange and is extubated 12 hours post procedure. That means after your banding of the esophageal varices secondary to significant upper gastrointestinal hemorrhage. Now, so he is extubated 12 hours post procedure. He is moved to a medical ward for ongoing management. 72 hours later, he becomes confused, agitated with evidence of tremors and paranoid ideation. What is the best treatment for his current condition? Now, can anyone tell me what exactly will be the diagnosis of the patient? What exactly has happened to this patient exactly after 72 hours? The options are benzodiazepine, IV haloperidol, then oral morphine, then quetiapine, thymine. So what exactly do you think is the correct answer in this patient? No, what exactly is the diagnosis? Right, very good, Chandani. So basically, the individual is having alcohol withdrawal syndrome. The patient is having alcohol withdrawal syndrome. So he is at risk of both delirium tremens and as well as the hepatic encephalopathy. So in case of this alcohol withdrawal syndrome, now what do you think is the most appropriate treatment for the management of alcohol withdrawal? That will be your benzodiazepines. That will be your benzodiazepines. It is not your thymine. It is not your thymine. So where do you give this particular thymine? The story of thymine comes when the individual has consumed alcohol having the hypoglycemic symptoms like in the form of seizures and all. But here what is the scenario? Like the scenario is the individual has undergone the esophageal variceal binding, right, banding, admitted to the general ward after extubation. After 72 hours, he has developed all these manifestations. Okay. So now the question of your hypoglycemia does not come in this particular scenario. Okay. So it is the alcohol withdrawal syndrome. What we give is the benzodiazepines. So we have short-acting and long-acting benzodiazepines. The short-acting benzodiazepines are lorazepam and as well as oxazepam. And long-acting benzodiazepines are diazepam and as well as the chlordiazepoxide. So that will be your benzodiazepine story. Right. Now we'll move on to the next clinical scenario. Okay. Now, no, Meet Patel. So if you see the clinical scenario there, the individual had a esophageal banding after 3 days getting admitted into the ward. That means for 3 days in the ward, he doesn't have alcohol to drink, right? And because of which, and that too, he was like a chronic drinker. 1 liter of vodka he was continuously consuming every day. Now for 3 days he doesn't have the alcohol, and because of which that precipitated the alcohol withdrawal syndrome. Okay. Right. Now you take the next question. Which of these statements is true regarding the use of the intra-aortic balloon pump? The options are: carbon dioxide is used to inflate the balloon. It is associated with improved survival in cardiogenic shock. It is commonly inserted via brachial artery. It is designed to improve the diastolic pressure proximal to the balloon. There is no risk of mesenteric ischemia when inserted correctly. Right. So what do you think is the correct statement regarding your intra-aortic balloon pump? Anyone? Right. So if you see the correct statement here, now in case of the intra-aortic balloon pump, the gas which will be there is not the carbon dioxide. It is the helium that will be there within the balloon of the IABP. Right. Now, the second one, if you take this intra-aortic balloon pump, it is the one actually administered for managing the cardiogenic shock. For managing cardiogenic shock, we administer or we place the intra-aortic balloon pump. But the studies have shown that as such, there is no increased survival in cardiogenic shock. Right, even though you are placing this IABP for the treatment of cardiogenic shock, but the studies have shown that there is no convincing evidence for increased survival in cardiogenic shock. So, like, let us just consider as a second option. If we don't have any other answers, then we will go with B. Okay. Now, you take C. It is inserted via brachial artery. Wrong. It is inserted via the femoral artery. Okay. Now, you take the fourth option. It is designed to improve the diastolic pressure proximal to the balloon is a correct statement. Now I'll just show you the intra-aortic balloon. Okay, so this is the intra-aortic balloon. So this particular balloon is inflated during diastole. So thereby proximal to the balloon, the pressure is increased. Right, proximal to the balloon, the pressure is increased. So proximal to the balloon, if the pressure is increased, that will increase the myocardial perfusion, because myocardium receives the blood supply during the diastole, whereas the remaining entire part will receive the blood during systole. So the balloon is inflated in diastole, augmenting the forward flow of the blood to the abdominal organs and improving diastolic pressure proximal to the balloon, thus optimizing the coronary perfusion. That is what is the advantage why the balloon has to be inflated during diastole. And it is placed through the femoral artery. It is not placed through the brachial artery. Now, in spite of the procedure, whatever it might be, like there is risk of mesenteric ischemia, because the balloon, it will be passing through your celiac trunk. So this particular balloon, when it is inflated, it can be blocking or it will be occluding the mesenteric arteries, celiac arteries, and thereby there can be risk of the mesenteric ischemia. So that is the reason why even your E is also incorrect statement. So the best answer here will be D, and the second best answer would be B. And if only one option is asked to opt, then go with D. That is fourth option. Okay, right. So the correct answer here is the D. Now we'll move on to the next clinical scenario. Okay. A 24-year-old man is admitted to the ICU after sustaining a severe head injury after falling from a height at work. So the patient had severe head injury. Right, the patient had severe head injury. CT head on admission demonstrates massive intracranial hemorrhage with midline shift, and clinical opinion is that of brain death. His family say that he previously expressed a wish to donate his organs if this situation ever arose. Which of the following would prevent testing for brain death? Administer 10 milligrams of morphine IV 2 hours priorly. Administer administration of bolus of atracurium 72 hours previously, core temperature 36 degrees centigrade, normal thyroid function test, serum sodium of 133 millimoles per liter. See, you should understand the question properly. Which of the following would prevent the testing for brain death? Any one of you, please. Core temperature 36 degrees centigrade. Why a core temperature of 36 degrees centigrade would prevent testing for brain death? Okay, now let me tell you. So what are the preconditions for testing for brain death? The preconditions for testing for brain death, it includes the following. The patient should be in deeply comatose state. The patient should not be hypothermic. The patient should not have any profound electrolyte or metabolic disturbances, right? And if you go back to the options, and atracurium, what exactly is this atracurium? It is a muscle relaxant. That it is a muscle relaxant, okay, right? But whenever you administer this morphine, what would be the problem? The administration of large doses of IV morphine 2 hours previously raises the possibility that the coma is secondary to a narcotic drug, and therefore brain death testing cannot be carried out reliably. So administration of 10 milligrams of morphine IV 2 hours previously would prevent the testing for brain death. Then that would be the best answer. That is the first option. And if one more option is asked to opt for, then you can go with the core temperature of 36 degrees centigrade, because even hypothermia also would prevent the testing from brain death, because one of the precondition for testing for brain death includes what? The patient should not be hypothermic. The patient should not be hypothermic. So the correct answer here is the A. Administration of 10 milligrams of morphine IV 2 hours previously should not be done, and that will prevent the testing from the brain death. Okay, right. Now we'll move on to the next question. Okay, which of these is an early complication of percutaneous tracheostomy carried out in the ICU? Hemorrhage, laryngeal stenosis, tracheal stenosis, tracheomalacia, then wound site infection. Right, so if you take the options here, the question asked is the early complication. The stenosis part and as well as the wound site infection, these are all the late complications. Right, these are all the late complications. Very good. So the correct answer here is the hemorrhage. So hemorrhage would be the early complication of percutaneous tracheostomy. Now what exactly you understand by this word tracheomalacia? Tracheomalacia in a newborn occurs when the cartilage in the windpipe or trachea has not developed properly. Right? So what is tracheomalacia? Where the cartilage in the windpipe or trachea has not developed properly. So now that particular trachea, instead of being rigid, the walls of the trachea are floppy, resulting in breathing difficulties soon after the birth. That is what is your tracheomalacia. That cannot be a complication secondary to your percutaneous tracheostomy. Right? It's a congenital abnormality. Okay, right. So the correct answer here is the hemorrhage. Now we'll move on to the next question. Right. So slightly tricky question, right? Please understand the question properly and then answer it. So a 28-year-old woman is rushed to the accident and emergency in a confused state. Okay. Her partner reports seeing the patient vomiting and breathing very rapidly before falling ill, at which point he called the ambulance. Empty aspirin packets were found close to the patient, and the partner estimates it has been approximately 45 minutes to 1 hour. Right, 45 minutes to 1 hour since the patient may have ingested the pills. The most appropriate first line management would be hemodialysis, activated charcoal, IV sodium bicarbonate, gastric lavage, intravenous fluid and electrolyte supplementation. IV sodium bicarbonate? No. Okay, let me explain to you about what exactly is the correct answer. So in patients who have taken a suspected aspirin overdose, the metabolic pathways to consider include the breakdown of aspirin, right? Breakdown of aspirin to the salicylic acid. And what would be the enzyme which is required here? That is the hydrolase or hydrolases. And where are these hydrolases present? They are especially prevalent in the liver. Now, more and more aspirin overdose has occurred. So what will happen to this enzyme? Saturation of these enzymes can occur in the overdose, causing an increasing in the plasma salicylate level. So the entire aspirin is being converted into salicylate. Now, the individual will have the clinical manifestations of the increased salicylate level. What would be that manifestation of increased salicylate level? That includes renal excretion of bicarbonate, creating the metabolic acidosis. So metabolic acidosis, that would be the primary systemic consequence. Okay, and once there is metabolic acidosis, that will stimulate the respiratory center, and thereby the patient will be having the hyperventilation. And because of hyperventilation, the patient will go into a state of respiratory alkalosis. Okay, so there will be metabolic acidosis and then respiratory alkalosis. Now, this metabolic acidosis and respiratory alkalosis, these are the things that can induce dehydration, and not only dehydration, that can also cause the electrolyte abnormalities, right? That can also cause the electrolyte abnormalities. Okay, right. Now, this particular dehydration and electrolyte abnormalities, how they have to be corrected? So in all the patients with aspirin overdose, the first line therapy must include the intravenous fluids and as well as the electrolyte supplementation, right? Now, what about the other options like activated charcoal and gastric lavage? Activated charcoal and gastric lavage should also be considered if the patient comes within 1 hour of ingesting the tablet. Now, by the time the ambulance have come, so he noticed that 45 minutes to 1 hour back, she has consumed the tablet. By the time the patient is being shifted to the hospital, definitely it will be more than 1 hour. So activated charcoal and gastric lavage at this particular, in this scenario, does not hold good, right? Does not hold good. Okay, now when will you give this sodium bicarbonate? See, in moderate poisoning, where salicylate concentration reaches, right, where salicylate concentration reaches 500 to 700 milligrams per liter, that is the point when your sodium bicarbonate should be given to create an alkaline urine which increases the excretion via the kidney. Okay, so when the sodium salicylate levels are 500 to 700, then we give this particular sodium bicarbonate. So what exactly are the levels that have been not mentioned? And not only that, secondary to your salicylate overdose, the patient will develop the hypokalemia. And whenever you are giving sodium bicarbonate will aggravate the existing hypokalemia, right? Sodium bicarbonate will aggravate the existing hypokalemia. So that is the reason why this hypokalemia must be corrected first before introducing the sodium bicarbonate. Then hemodialysis. Now, when will you do the hemodialysis? Hemodialysis is reserved for patients with severe poisoning with plasma salicylate concentration more than 700 milligrams per deciliter. Okay, when the plasma salicylate level is more than 700 milligrams per deciliter, that is the point when we give the hemodialysis. Now, when the plasma salicylate levels are more than 700 milligrams per liter, what would be the clinical feature? Such particular patients are usually in a state of coma. Right, such particular patients will be in a state of coma. So comatose patients with salicylate overdose, that tells that the patient's salicylate level will be more than 700, where we do the hemodialysis. But our patient is in a state of confused state, vomiting and rapidly breathing. It doesn't mean that, so it tells you that the patient is not in coma. So hemodialysis is not required at this particular point of time. So the correct answer here is the intravenous fluids and as well as electrolytes. Yes, so all of you, right, tell me, have you understood why the answer is intravenous fluid and electrolytes? Yeah, yes, Dr. Reformer. Bleeding tendencies can also happen, but not as an acute event. Chronic overdose that can cause the bleeding tendencies. That is also one of the feature of the salicylism. Right. Now, once we are done with this particular question, we'll move on to the next one. So, you take the next clinical scenario. So, the next clinical scenario is a 43-year-old man presents with profuse vomiting, abdominal pain, and faint metallic taste in the mouth. The patient is mildly jaundiced on examination with faint green discoloration of the gums. The patient denies taking any recreational drugs but mentioned he has been away on sabbatical in rural India. The most likely diagnosis is copper poisoning, magnesium poisoning, iron toxicity, liver failure, organophosphorus poisoning. So you see the points here. What are all the features? Right, very good. So this is suggestive of the copper poisoning. Okay, so copper poisoning most often occurs due to ingestion of copper salts, contaminated food products. Right now in India, so where is this particular individual staying? In the rural India. So in India, copper sulfate is used in fertilizer and fungicides and is the most common cause of the copper poisoning. Right, and whatever the individual ingests, the copper that will accumulate in the liver and it is eliminated through the bile. Now what will be the features of the copper poisoning? Profuse vomiting, diarrhea, abdominal discomfort, then this metallic taste in the oral cavity. These are the features of the copper poisoning. And when the copper poisoning is like more severe, right, if in more severe cases, there will be hemolysis. Right, there will be hemolysis and there can be also hepatorenal failure. There can be also the hepatorenal failure and subsequently the individual may die. Right, and what exactly is the treatment that we give for the copper poisoning? The drugs that we give is the zinc, trientine, and then dipenicillamine. So these are the drugs what we give for copper poisoning. Then what about this magnesium poisoning? See, magnesium toxicity most often occurs in patients with renal failure. And what will be the clinical features of magnesium poisoning? That includes narcosis, muscle weakness, and hyporeflexia. That is absence of deep tendon reflexes. That will be there in case of magnesium poisoning. And what is the drug that we give for magnesium toxicity? That is calcium gluconate is being given for cardioprotection. Then what about iron toxicity? See, iron toxicity is usually seen in individuals who is undergoing regular blood transfusion. And what will be the features of iron toxicity? That includes black or gray vomitus and gastrointestinal disturbances including pain and diarrhea. Okay, so that can happen in case of iron toxicity. Then you take liver failure. Patients with liver failure, they go into a state of encephalopathy, that is hepatic encephalopathy can be there, where the individual will be in a state of the altered sensorium, reversing of the sleep rhythm and the presence of the asterixis and jaundice. So these all will be the features of your liver failure. Then why not the organophosphorus poisoning? See, the organophosphorus poisoning, what will be the features? That includes anxiety, right? So you are very much aware of this sludge. Right, so excessive salivation, lacrimation, urination, defecation, right, gastrointestinal emesis. Okay, and in life-threatening situation of organophosphorus poisoning, there can be respiratory failure where the individual will be requiring atropine. Okay, so the answer here is the copper poisoning, where the patient will present with vomiting, abdominal pain, metallic taste within the mouth, and greenish discoloration of the gums. The treatment will be trientine, zinc, and as well as the dipenicillamine. Okay, right. So having said this, we'll move on to the next question. A 22-year-old unconscious man, right, 22-year-old unconscious man, is brought into the accident and emergency. He was found lying alone on street by passers-by who called the ambulance, and crew mentioned seeing needles on the floor. The patient's GCS is 12. He has respiratory rate of 10, blood pressure 97/65. During your examination, you notice pinpoint pupil, right? Pinpoint pupil. The most appropriate management in this patient is mechanical ventilation, naloxone, intravenous naloxone, naltrexone, methadone. Right, so very good Chandani Keswani. So the correct answer here is the intravenous naloxone. So now this particular patient is most likely suffering from the opiate overdose, right? Opiate overdose, which is treated by opiate antagonists such as naloxone. Now, what are the points suggesting it's an opiate overdose? That is the presence of pinpoint pupil. Next, respiratory depression of 10 per minute, and the individual being in a state of the comatose. These 3 points, pinpoint pupil, respiratory depression and comatose state, that tells that the individual is having the opiate overdose. Then what about the other options? You take methadone. What is methadone? Methadone, it's a partial opioid antagonist, and it is useful in weaning patients off the drugs such as the heroin. Okay, so in heroin overdose, we give this particular methadone, right? Now, what about the other options? Now, mechanical ventilator. See, since the patient is able to maintain the respiratory effort, how much is the respiratory rate? That is around 10 per minute. So since the patient is able to maintain the respiratory effort, mechanical ventilation would not be necessary in this individual. Now, what about the other options like naltrexone? So naltrexone is another opioid antagonist. This has longer half-life, right? This has longer half-life than naloxone. So it is less often used in an emergency situation and more for long-term dependency control. So for long-term dependency control, we give this intravenous naltrexone. Then what about naloxone? Naloxone is an irreversible opioid receptor antagonist. So because it's an irreversible opioid receptor antagonist, it is not appropriate in an emergency situation since this requires short-term reversal, right? This situation requires short-term reversal. So that is the reason why the correct answer here is the naloxone. Right, Sushant, the other point in case of your pontine hemorrhage is, in pontine, okay, very good Sushant, but remember in pontine hemorrhage, there will be very severe hyperthermia, which is not being mentioned in our question, okay? So, that's why we don't take the consideration of the pontine hemorrhage. Otherwise, in pontine hemorrhage, you will have the pinpoint pupils. Right, and other points is the individual is having needles lying. That is also the point to tell you that the individual is having the opioid overdose. Okay, right. Now, see, if he specifically mentioned the heroin overdose, then we can give methadone. But the points they are all in favor of the opioid overdose, particularly the opioid overdose. Right. Now, we'll move on to the next clinical scenario. Right. Now, the other one is a 26-year-old man with a past medical history of asthma presents to accident and emergency with difficulty breathing. He has a respiratory rate of 35 beats per minute and heart rate 120 beats per minute and difficulty in answering the questions. On auscultation, there is polyphonic wheeze that is being heard, and the saturation is 93%. The patient is unable to perform a peak expiratory flow. The most appropriate treatment is nebulized adrenaline, intravenous magnesium sulfate, 100% oxygen, salbutamol nebulizer, oral prednisolone. Right, very good, Dr. Reformer. So the correct answer here is the 100% oxygen. Now let me tell you what exactly is this particular patient coming under. So this patient, he comes under what is called as severe asthma. Right, he comes under what is called as the severe asthma. Right, so now what are the points to tell that the patient is having the severe asthma? Number one, the saturation. So saturation, if it is less than 93%, we consider it as severe asthma, And the next point is, okay, the next point is the respiratory rate, right? If the individual respiratory rate is more than 30, that also we consider it as the severe asthma. And he is not able to do the peak expiratory flow rate. But if the peak expiratory flow rate, if it is less than 33% of the predicted value, that also comes under your severe asthma. And partial pressure of oxygen, if it is around less than 56 millimeters of mercury, then also we consider it as severe asthma. So now what are all the points which we can take into consideration that the patient is having the severe asthma is, which has all been given as saturation reduced and respiratory rate is more than 30 per minute. So these are the points to, and even heart rate is also increased. Heart rate, right, more than 110, which we consider it as severe asthma. So in a situation of the severe asthma, the important treatment is the 100% oxygen, right? So this optimal management is oxygen, that is to maintain the SpO2. See, by giving oxygen, you have to maintain the SpO2 between 94 to 98%, and thereby you can combat the hypoxemia. Now, what about the other options? You take your salbutamol nebulization, that will be the second line therapy. That will be second line therapy in the presence of hypoxemia. So when there is hypoxemia, the first important treatment will be the 100% oxygen. Okay. So in acute asthma, for suppose if the patient is having normal oxygen levels, in that case, your high dose salbutamol therapy, that would be the first line therapy. If the patient is having normal oxygen. But our patient is having hypoxemia. That is the reason why 100% oxygen is considered as the first line treatment. Now, what about this nebulized adrenaline? So nebulized adrenaline, it acts as a non-selective beta-2 agonist when compared to salbutamol or terbutaline. So that is the reason why there is no role of your nebulized adrenaline. Now, what about the other options like oral prednisolone? See, the steroid, which is nothing but steroid. So when will you give this steroid is this high dose steroid therapy following oxygen and bronchodilator therapy interventions may be given orally or parenterally depending on patient's ability to swallow. Okay, so this prednisolone is not the first line. After oxygen, after bronchodilator therapy, then comes your prednisolone. So that is why it is gone. Now, what about this magnesium sulfate? Magnesium sulfate has bronchodilatory effect and is considered only if there is no response to inhaled bronchodilators. When there is no response to inhaled bronchodilators or in life-threatening asthma, we give this intravenous magnesium sulfate. So the correct answer here will be the 100% oxygen would be the definite answer here. Okay, right. Now, so this particular patient comes under what? Acute severe asthma. So, taking the next clinical scenario, right? A 65-year-old Asian man with type 2 diabetes complains of central chest pain, which he describes as severe and crushing in nature. Right? Severe and crushing in nature. On appearance, the patient appears anxious, sweaty, and has difficulty breathing. The most appropriate first-line treatment is beta blocker, glyceryl trinitrate, non-steroidal anti-inflammatory drug, oxygen therapy. Yes. So now, what exactly do you think is the clinical scenario of the patient? That is the coronary artery disease. Sushant, aspirin is not there. Okay, aspirin is there in our options, but still. Right. So in an acute presentation, of suspected acute coronary syndrome, what is very important for us is the pain relief, right? We don't have any other investigations as such. We don't have ECG and all. We are suspecting. Why? Because age of the patient is 65. Patient is having type 2 diabetes mellitus. So in a suspected acute coronary syndrome, the pain relief, you can achieve it by the glyceryl trinitrate. You can achieve it by glyceryl trinitrate. Now, what about the other options? I'll come to your aspirin also. What about the other options? NSAIDs. NSAIDs do not provide relief, do not provide adequate pain relief in case of the acute coronary syndrome. Now, when can you give this aspirin is after giving this glyceryl trinitrate, a loading dose of 300 milligrams aspirin should be given unless the patient is allergic to it. Okay, so following the pain relief, you can give this aspirin. Now, what about oxygen therapy? Oxygen therapy should not be given routinely unless oxygen saturation falls below 94%. So when your SpO2, if it is less than 94%, that is the point when you can give oxygen therapy. So in our patient, like nothing is being mentioned that there is hypoxia. And you take this beta blocker. See, when will you give this beta blocker is once the patient is stable, then beta blockers are given for relief of ongoing chest pain. So we don't give the beta blocker as a first line therapy. So along with glyceride, for suppose, if the patient is having significant hypotension, then we avoid giving glyceryl trinitrate. What would be the alternative? The alternative would be the morphine, that is opioid. Right, the alternative would be the morphine that we give. Okay, so here the correct answer is the glyceryl trinitrate. And when will you give your aspirin? You need to give this aspirin after the pain relief, following the pain relief. So in a suspected acute coronary syndrome, the pain relief, it can be achieved by your glyceryl trinitrate, or the intravenous opioids should be given to relieve the patient's symptoms. Right, next. Okay, so a 54-year-old known hypertensive male presented with 3-day history of shortness of breath. The patient reported feeling unwell with sharp pain in the left side of the chest, right, and loss of appetite. His clinical findings included the heart rate of 117 beats per minute, blood pressure of 97/85 millimeters of mercury, temperature 37.2 degrees centigrade, and respiratory rate of 22 breaths per minute. The respiratory examination showed reduced air entry and hyperresonance on percussion. So what do you think is the most likely diagnosis in this patient? Tension pneumothorax, pneumonia, pleural effusion, aortic dissection, pulmonary embolism. Right, very good. So the correct answer here is the tension pneumothorax, right? So what are the points that tells you that individual is having the tension pneumothorax is? One is your respiratory distress. That is one important point. And one of the very, very important finding to tell it as tension pneumothorax is reduced air entry and hyperresonance on percussion. These are the points to tell that the individual is having the tension pneumothorax. Whereas you take the next two options. In case of pneumonia on percussion, it will be woody dull note, and in pleural effusion on percussion, it will be stony dull note. So your pneumonia and as well as the pleural effusion is being ruled out. Then coming to the aortic dissection. See, what will be the clinical presentation in case of the aortic dissection? The individual will have a tearing pain, and the blood pressure usually in case of aortic dissection will be on the higher side, but our patient is having a blood pressure of 97/85, which does not go in favor of your aortic dissection, and the patient will have a tearing type of pain. That is what will be the classical presentation in case of the aortic dissection. Okay, and this aortic dissection, it can cause a complication, that is it can cause pleural effusion, or it can cause even pericardial effusion, right? So in pleural effusion or pericardial effusion, you will have a dull note but not the hyperresonant note. So that is the reason why the aortic dissection is being ruled out. Okay, then coming to pulmonary embolism. See, why will you rule out, or how will you rule out your pulmonary embolism is, pulmonary embolism, the patient will present with abrupt shortness of breath, right? There will be abrupt shortness of breath. Okay, along with this abrupt shortness of breath, the individual will have hemoptysis and pleuritic chest pain. So our patient is giving a history of like 3-day history of shortness of breath, which is usually unlikely in case of the pulmonary embolism. Right, yes, Meghavi, yes, in dissection there can be difference in the upper limb blood pulse also, but it all depends upon where exactly is the site of the dissection, right? So for suppose if the site of dissection is within the descending aorta, then the left upper limb, the pulse will be less than compared to that of right upper limb. Okay. Yeah, yes, Sushant. Even for tension pneumothorax, that 3 day history, it is like too long. It's like little question mark only. It is like little question mark even for tension pneumothorax. But the points which are very strongly favoring your tension pneumothorax is the hyperresonant note and as well as reduced air entry. These are the 2 points strongly favoring your tension pneumothorax compared to any other option which has been given in the question. Right? Even for tension pneumothorax, the history should be like acute in onset, right? But examination findings like hyperresonant note and reduced air entry, they are the one which are telling you that it is a pneumothorax. Okay, right? Because we don't have any other options with hyperresonant note and reduced air entry there. Okay, you see the next clinical scenario. A 47-year-old man presents to accident emergency with a 3 day history of melena. The patient appears pale and has a heart rate of 110 beats per minute and blood pressure of 105 by 71 millimeters of mercury. The patient reports suffering a sprained ankle 1 week previously and has been using NSAIDs to control the symptoms. The most likely diagnosis is the duodenal ulcer, gastric ulcer, colon cancer, rectal varices, diverticular disease. No. It is not the duodenal ulcer. Right. So the correct answer is the gastric ulcer. The correct answer is the gastric ulcer. Now, see, what is the precipitating factor for the development of the ulcer here? NSAIDs. Now, this non-steroidal anti-inflammatory drugs, they are at increased risk of developing gastric ulcer then compared to that of the duodenal ulcer, right? Then compared to that of the duodenal ulcer. So that is the reason why the gastric ulcer is very the correct answer. And why is that these NSAIDs can cause the gastric ulcer? You take NSAIDs like aspirin or indomethacin, they reduce the mucosal prostaglandins, right? They cause a reduction of mucosal prostaglandins by inhibiting the cyclooxygenase pathway, and this leads to increased damage to the gastric mucosa from increased gastric acid exposure, causing pain, and in severe cases there can be even bleeding also. Now, what about the duodenal ulcer? See, the duodenal ulcer perforation occurs more commonly than the gastric ulcer, but the duodenal ulcer is more common in case of the H. pylori infection than compared to that of your NSAIDs. Okay, NSAIDs exposure can cause most commonly the gastric ulcer rather than the duodenal ulcer. Okay, so the correct answer here will be the gastric ulcer. And what about the other options like the colon cancer? See, colon cancer is often accompanied by a distinct set of symptoms that includes change in regular bowel movements. In colon cancer, there will be change in regular bowel movements, change in frequency and consistency of the stool, abdominal mass, and rectal bleeding. All these will be the features of your colon cancer. Okay, and what are the other features of malignancy, such as unexplained weight loss, should always raise the suspicion of the malignancy, which is not the feature here. So your colon cancer is being ruled out. You take rectal varices. Rectal varices can produce painless bleeding, right? Painless bleeding. However, they tend to occur in older patients and are not associated with analgesia use. So that is the reason why rectal varices are less likely in this case. Then diverticular disease. Diverticular disease is most often asymptomatic in most patients unless complicated by diverticulitis. And that too, in case of diverticular diseases causing diverticulitis, where will be the pain? The pain arises in the left iliac fossa, right? The pain arises within the left iliac fossa with changes in normal bowel habits and intermittent pain. So the correct answer here will be the gastric ulcer, but not the duodenal ulcer, right? Now we'll move on to the next question. Okay, a 17-year-old male is brought unconscious to accident and emergency. Unconscious. His friend reports they were at a nightclub while celebrating his birthday. They deny having any alcohol or the recreational drugs. The club has strobe light effects, and while these were on, he suffered a seizure. The friends called an ambulance, and while waiting, the patient suffered another seizure shortly after the first. While waiting for the ambulance, he had another episode. He was not conscious during any of the attack. The most appropriate treatment is rectal diazepam, intravenous thiamine, intravenous phenytoin, intravenous thiopentol. What do you think is the correct statement here? Okay, we have the other option, that is intravenous lorazepam as well. Right, so this is the scenario of the status epilepticus. This is a scenario of the status epilepticus. Now, right, so in case of the status epilepticus, what exactly do you think as the drug of choice? That will be the intravenous lorazepam. Intravenous lorazepam. Okay, right. And what about the other options like intravenous thiamine and all? See, this intravenous thiamine is given during resuscitation if alcohol abuse or malnutrition is being suspected. That is the point when we give this intravenous thiamine. Okay, right. Then you take midazolam. Intravenous midazolam is optimal for controlling refractory status epilepticus in children. And compared to your intravenous midazolam, the best will be the intravenous lorazepam. And thiopentol. You take this intravenous thiopentol is given only in refractory status epilepticus. Right, midazolam and thiopentol, both of them, they are given in refractory status epilepticus where the individual is not responding to your lorazepam. Okay, right, it is not your Verney case. It is not the Verney case. Okay, because what they say, they deny any alcohol or recreational drugs. So we will just go along with the history. Right, so one last question. Right, a 75-year-old woman presents with confusion to the accident and emergency. She was brought in by her neighbors who found her outside her house in her night clothes during the middle of the middle of the day. She appears edematous in appearance, particularly of her neck. The patient's hand is visibly shaking, and while coughing, a rust-colored sputum is produced. Blood tests reveal mild hyponatremia while blood pressure is 110/82. So what do you think is the most likely diagnosis in this patient? So what are all the important points here? Confusion, right? And who found her outside her house in her nightclothes during the middle of the day? And edematous in appearance, that is another important point. Edematous in appearance. Hand is visibly shaking while coughing, a rust colored sputum is being produced. So what do you think is the very good? So the correct answer is the myxedema coma. See, myxedema coma is a medical emergency that results due to progression of hypothyroidism, typically in elderly females. Right, typically in elderly females, you very commonly come across this myxedema coma. And there are a number of factors that can exacerbate the pre-existing hypothyroidism into a state of myxedema coma. Right, number of factors are there. What are the precipitating factors where the hypothyroidism can go into a state of the myxedema coma? One of the very important risk factor is the hypothermia. Right, hypothermia, that is one important risk factor. Then hyponatremia is another important risk factor where hypothyroidism can go into a state of the myxedema coma. The another important is heart failure. So what is that our patient is having? Our patient is having mild hyponatremia. That particular hyponatremia might have precipitated the hypothyroidism into a state of the myxedema coma. Right, and you take this rust colored sputum. Right, rust colored sputum. Although this particular rust colored sputum is strongly suggestive of pneumonia, this is likely to be the precipitating that caused the underlying diagnosis of myxedema with signs of heart failure, hyponatremia and confusion. So the another important precipitating factor for the development of myxedema coma is infection. Right, is infection, that is pneumonia. Pneumonia can also precipitate, right, pneumonia can also precipitate the individual from hypothyroidism going into a state of the myxedema coma. Right, yes, Ravi Kiran, did you understand why the pneumonia? right? But nothing given about the thyroid picture. See, if you take the points in favor of the hypothyroidism or in favor of myxedema coma, one point is myxedema coma is very commonly seen in elderly females. That is one point suggestive of myxedema coma. And the other points in favor includes edematous in appearance, right? Hypothyroid patients, how do they appear? They are like edematous in appearance. And a precipitating factor for this myxedema coma in this patient is the hyponatremia. But you take the other options, no other option will go into this particular picture, right? No other option. If you are suspecting only pneumonia, that is incorrect. Then why do you think that the patient is edematous? Why do you think that the individual is in a state of confusion if you are suspecting only pneumonia, right? So only pneumonia you cannot consider, right? And you take sepsis. Sepsis is unlikely in this patient despite the signs of infection. Why? Because in sepsis, usually there will be hypotension, but our patient is having the normal blood pressure. So your sepsis is ruled out. Then you take the lung cancer, right? What all will be the signs of malignancy? Weight loss, cough, blood-stained sputum will be there. In case of lung cancer, there will be blood-stained sputum, not the rusty sputum. So that is the reason why lung cancer is being ruled out, right? Next, the other points are like, what is Schmidt syndrome? See, Schmidt syndrome is otherwise known as polyglandular autoimmune syndrome, right? Polyglandular autoimmune syndrome. Which type? Schmidt syndrome, it comes under polyglandular autoimmune syndrome type 2, right? Type 2. Now what all will be there in polyglandular autoimmune syndrome type 2 is, that includes the Addison's, right? That includes the Addison's. Okay, so it consists of Addison's and is most commonly associated with autoimmune thyroid disease, right? Autoimmune thyroid will be there in case of the polyglandular autoimmune syndrome type 2, and the other thing is type 1 diabetes mellitus. Okay, so these are all the points which are there in the Schmidt syndrome, right? Now, which these features are not there in our patient, so that is the reason why your Schmidt syndrome is also being ruled out. Okay, so the correct answer here will be the myxedema coma, right? Myxedema coma. And one okay, so we'll just wind up this particular session with the following clinical scenarios, right? And the PDF or the PPT of this particular session will be available on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, or you will get this even in DBMCI Premier Group in Telegram channel. I'll be sending this PDF. Okay, right? So with this, I'll wind up this particular session. See you again in the upcoming sessions of the emergency medicine clinical scenarios. Thank you very much.